Hi, everyone. Welcome back to the clinical track. Again, I'm Jennifer Gould, the moderator for this track. If you happen to miss the bonus raffle code that was entered in the implementation track, it was exudate. So make sure to throw that in the raffle. Our next speaker is Anith Pillai. He is a graduate of the University of Houston College of Optometry and the owner of Evolutionary Eye Care. His practice primarily focuses on management of anterior segment disease, including specialty contact lens fits. And he's put together a really comprehensive discussion about orthokeratology and how it can reshape vision.
Hi, everyone. Thanks for joining this session on orthokeratology and reshaping vision. I hope you enjoy it. We put some time in putting it together, and I think it has a lot of informative information. So let's just get rolling. These are my financial disclosures. Won't have any impact on this lecture. And I'm not going to talk too much about why we should do ortho-K, why myopia management or myopia control matters. But I will just address this one slide. And it shows that the higher the myopia, the more myopic progression a child has, the more likely of retinal issues later on in life. There's something we can do besides just doing glasses and regular contact lenses. There is intervention we can do to help slow this progression down, and I hope everyone that's joining this session realize the importance of it. But what we're going to cover today is ortho-K, how it works, its architecture, going through topography, and of course, when things go wrong, troubleshooting cases. So this is specifically about design and troubleshooting and how to do an ortho-K case. So what ortho-K is the temporary reshaping of the front part of the eye. So we all know that it uses a ridged gas permeable lens, and it's gently reshaping the front surface of that cornea to attain vision correction and also achieving some myopia control effect. And the way it actually accomplishes this is with hydraulic forces. So it uses our own tear film. The tear film underneath the RGP of the ortho-K design is actually manipulated to make these corneal changes for vision correction and also induce this myopia control effect. And this is what it looks like. So this bottom picture is an ortho-K lens on the eye, and that top picture is depicting what's going on. So one of the big misconceptions about ortho-K is that we're mushing the central cornea, where this flattening that we obtain is by mechanical compression. And you'll see through this fluid reservoir depiction that we'll actually have a thin layer of tears underneath the ortho-K design. It's not actually pressing on the cornea. It's creating this reservoir system of a positive push force centrally and a negative pull force in the mid-periphery. So that shifts the cells and changes their structure to cause not only the vision correction changes, but also the myopia control effect. And I'll have a few histology slides. I know it's not everybody's favorite, but I think it's important to show because when we're making these cellular changes, it's not just movement. It's actually the cellular structure itself. So under this reservoir, we're having this positive pull force and negative pull force. So that's migrating the epithelial cells from the center to the mid-periphery. Okay, so we're actually having more cells in the mid-periphery, but also with this reservoir, we're creating an osmotic gradient. So the central cells will actually lose some of the cytoplasmic fluid. Those cells will thin out. And in the mid-periphery, it'll be the exact opposite, and those cells will gain cytoplasmic fluid and they'll thicken. So this hydraulic force system that we've created is not only migrating cells, but it's actually causing an osmotic gradient where the cytoplasmic fluid is affected. So central cells will thin, mid-peripheral cells will actually thicken in addition to this migration. So it's not a mechanical structure. We're not pressing on the cornea. In fact, we'll get into this later where if we're starting to see mechanical compression and epithelial compromise, that's actually a poor fitting design. So what all does ortho-K affect? Does it affect the entire corneal structure, just the epithelium, just the stroma? Does it have any endothelial effect? Well, from what the studies show, mostly epithelium. All right, almost everything you're doing is an epithelial change. Almost all of the vision correction is due to epithelial changes. And I showed you that on that histology slide where we'll have that central thinning of the cellular layer of the epithelium and that mid-peripheral thickening. In the endothelium, however, we're really worried here because if we're manipulating the cellular architecture of the endothelium, we could have some issues. We don't want any problems with that pump function. We want to make sure the endothelium is nice and intact. And it's been looked at in 1 year, 2 year, 7-year studies. And really what the consensus is, yeah, we're okay on the endothelium. We're not causing any damage. The effects of it are not clinically significant, and none of the vision correction changes are happening at the endothelial level. So most of these changes are happening at the epithelial level. Some mid-peripheral stromal changes can happen, but the endothelium, we're not causing any damage there. And this is, again, another histology slide. I think it might be the last one here, but it's just depicting not only are those cells migrating, but they're also swelling up in that mid-periphery. So there's more cells in the mid-periphery, but they're also thicker. And in that central area, there's less, but they're also been thinned out. And that's accomplished by the hydraulic forces from this fluid reservoir of an Ortho-K design. Now let's go into each individual aspect of an Ortho-K retainer. So most modern designs have kind of this 4-curve system where you have the central base curve, then a surrounding reverse curve, an alignment curve, and then a peripheral edge. There are a few more complex designs that include multiple alignment and multiple reverse curves, but in general, these are the 4 that you're going to be dealing with. So let's go into these one by one. The base curve, right in the center, that area of what looks like central bearing, seen there in the red arrow on a fluorescein image, and then the topographical depiction on the bottom. So the base curve here is unlike any other RGP design. If you're a specialty contact lens fitter or have done a lot of RGPs, you're used to manipulating that base curve to alter the fit. Well, in Ortho-K, that's not what we're doing. The base curve has absolutely nothing to do with the fit. If there's a fit issue, do not manipulate the base curve. That is not the area you want to mess with. This is purely for treatment effect. How much refractive error are we correcting? How much myopia are we correcting, or hyperopia or astigmatism? This is the area for correction. And how are we achieving that correction? As I said before, it's not mechanical. We don't want any central applanation or epithelial disruption. And this is what the tear layer looks like underneath the lens. So you'll see underneath that base curve, which looks like bearing on the bottom half of that image, you'll see that there's actually a very thin layer of tears, about 5 to 10 micron, depending on the myopia you're correcting. So we don't want compression. In fact, if we start to see epithelial disruption or central keratitis, that's a poor fitting design, and we need to make modifications to that. So you'll have this thin layer in the base curve. Now, it'll look like bearing on slit lamp. And the reason for that is the molecular weight of sodium fluorescein. So when you put that fluorescein dye at the slit lamp and view what the RGP looks like, unless you have 20 to 25 microns of clearance, it'll appear like bearing. So when you see bearing at that central base curve, you likely don't have compression. You'll still have a very thin layer. It's just under that 20 to 25 micron threshold of what we can visualize at the slit lamp. So again, we're using those hydraulic forces to cause that flattening. It's not a mechanical compression. In fact, if we had mechanical compression, you would see significant SBK, and that's not a desired result when we're doing a properly fit Ortho-K retainer. And if you don't believe me, here's an OCT image of it. This is an anterior sag OCT image of an Ortho-K design on top of a cornea. And you see centrally, there is no touch. There is a thin layer of clearance there, and that's exactly what we want. And in that mid-periphery, it steepens up to cause that negative pull force, but that positive push force centrally is not due to mechanical compression. It's due to those hydraulic changes we're creating by the reservoir system. So even on OCT, and you can do this if you have an intersegment OCT capability, get your Ortho-K patient underneath it, and you should see that thin layer right underneath the design. Again, purpose of the base curve, nothing to do with fitting, purely refractive error correction. This is a big concept for a lot of docs to get over, because you're so taught to change the base curve when you're manipulating RGPs or any contact lens really. But please remember, base curve, nothing to do with the fit. This is purely due to vision correction. And to be honest, most troubleshooting in Ortho-K doesn't happen at the base curve level. The next curve is the reverse curve. On the top image, the fluorescein image, you'll see the reverse curve as that area of pooling, and the red ring on the bottom image on the topographical representation. And here's the tear layer depiction again. So again, the base curve right in the middle with that tear film. And then you see this ramping up of a lot of fluid layer underneath the Ortho-K retainer. The reverse curve is typically the steepest area of the design. This is where the negative pull force is happening. And it's also where that mid-peripheral steepening is going to occur on your topographical analysis. And I like to say this is where the magic happens in Ortho-K. For those that follow myopia control, you know what we're trying to do is create a peripheral myopic defocus. That term comes up a lot. And that peripheral myopic defocus, that retinal image shell is created by that reverse curve. That mid-peripheral steepening is what causes those light rays to now focus anterior to the retina instead of posterior to it. That's what creates that peripheral myopic defocus. And that's what we need for a good myopia control effect. So everything we're doing with Ortho-K to limit progression is happening by this reverse curve. That's why I say this is where the magic happens. This is also where you're going to raise and lower the system. So if you have too much sagittal depth or too little sagittal depth, not altering the base curve to manipulate that, you're going to be altering the reverse curve. Next up is the alignment curve. And it's the second area of bearing that you'll see at the fluorescein image. And on the topography, you'll see it'll be immediately adjacent to the mid-peripheral red ring. And the alignment curve is, believe it or not, about alignment. Right? This is where a lot of centration occurs. And on the tear film analysis here, you'll see this area is actually a lot closer to bearing than even the base curve. On the base curve section, you'll see that thin layer of tears and then that steepening in the reverse curve. But when you come back to that alignment curve, you'll see that's pretty tangential to the mid-peripheral cornea. And that's what we want. We want this area to align properly 360 degrees around that corneal area. That's what helps the lens stay in place and center properly. Now, we don't want keratitis. We don't want it to be overly steep or landing too harshly where it's rubbing against the cornea. So you shouldn't see keratitis anywhere in a properly fit Ortho-K design. But the alignment curve is more representative true bearing than actually the base curve. And as I said, it's going to be aligning with that mid-peripheral cornea. This is the area where you'll be making adjustments for centration. So not the base curve. Remember, base curve is only for treatment error, treatment correction, vision correction. Anything to do with fit, get away from the base curve. Alignment curve is where you want to make those changes. So you see superior or inferior decentration, you're going to make modifications at the alignment curve. I'm not going to talk too much about eccentricity. It goes a little bit beyond the scope of this lecture, but I do want to address it here quickly. What eccentricity means, the definition of it is just the rate of flattening. How much is that cornea flattening compared to that central area? And what's the rate of that? That's what eccentricity means. And the lower the eccentricity, the steeper that alignment curve needs to be. The higher the eccentricity, the flatter that alignment curve needs to be. Now, I don't want you to just memorize lower eccentricity, steeper AC. I want to show you why that's the case. So eccentricity is sometimes confused because of how the numbers are depicted. So again, it's the rate of flattening. How much is it flattening from that central area? And if you look at this top image, you'll see that that 0.6, that first curve, is a bit flatter than 0.5 and 0.4. So a 0.4 eccentricity, which is a lower number, is actually going to be steeper in that mid-peripheral cornea. And the reason for that is a steeper mid-periphery is flattening at a lower rate. So it's actually depicting the amount of flattening. That's why a larger absolute or a larger number like 0.6 is going to be flatter, but a lower number like 0.4 is going to be steeper. So if you have a 0.6 eccentricity, the alignment curve can be flatter at that edge, okay? But when you have a 0.4 eccentricity, and this is a cornea with the same central case, we're only manipulating the eccentricity here. You have a same central K and going to a 0.4 eccentricity, that alignment curve needs to be steeper to land properly. And that's what this slide is showing. So again, for all you RGP junkies, the alignment curve is where you want to manipulate how it's centering, how the fit is going. Don't manipulate the base curve. Go to the alignment curve. That's where the fit of the design is happening. And you want that 360-degree seal off in the alignment curve. The reason for that is when you have this positive push force in the base curve and then the negative pull force in the reverse curve, that's going to be null and void if the alignment curve isn't sealing it all off, isn't keeping it in that area. If the alignment curve is lifting off the cornea, then that negative pull force from the reverse curve is just going to dissipate. All those tears are going to flood back out, and you're not going to have a proper treatment zone. So the alignment curve having 360 degrees of seal is important to keep that reservoir intact of the reverse curve negative pull force and the base curve positive push force. And finally, the peripheral curve. The very last curve, you see a little area of pooling at the very edge. It's probably the second steepest area under an Ortho-K design. The peripheral curve is very similar to other RGP designs. It's important for ocular health. So you want that proper tear exchange, maintaining a healthy corneal environment. You don't want that seal off. You want some tear exchange underneath an Ortho-K design as well, just like you do with an RGP. Now, if you have too much edge lift, just like with any other RGP, the patient will feel awareness and discomfort. So you don't want too much edge lift, or that will cause comfort issues. So you want just enough to make sure that we're having a healthy corneal surface. And if you start to notice kind of the scattered SBK or not enough tear exchange, manipulate that peripheral curve to get some more tear exchange underneath there so that we're not causing any corneal compromise. And obviously, if the patient is complaining of discomfort, especially after a week or two of wear, look at that peripheral curve, see if there's too much edge lift, and you can bring that back down. This is one of the questions I get the most. Do you need to have topography to do Ortho-K? Now, you can certainly design Ortho-K retainers without a topography. There are many labs. You can send in your manifest refraction. You can send in your auto Ks or central Ks, however you obtain them. Give an HVID. You can even monitor progression. Watch what the retainers look like at slit lamp with fluorescein. Do an over-refraction to see if their myopia is changing. It's all possible. I do not recommend you go that route. If you ask me personally, yes, I think you need topography to do Ortho-K properly. You really don't know what's happening at night when these kids are sleeping in these retainers. How you assess an RGP at the slit lamp is not what's happening while the kid's sleeping in it. Number one, when they're in your exam chair and you have in a slit lamp, they're awake, their eyes are open. Ortho-K is designed in a closed eye environment. It's completely different. Also, they're sitting up, their chin in a chin rest, forward against the bar. I doubt they sleep that way. So you need to know what's happening at nighttime when they're laying down with the eyes closed, because that's when the treatment's happening. And that's what the topography shows. You really have no idea what's going on without a topography. And to make modifications without these maps, it's truly, truly difficult. And I think if you're going to make the time investment in the monetary investment to really get into myopia control and having Ortho-K as part of your practice, get a topographer. There's many different maps that you're going to be using. I use every single one of these maps when I'm doing a pre-fit design or even post-Ortho-K analysis. So we're going to go into each of these maps and when to use them and why they're important. So first, we'll go into the axial map. This is probably what we're most accustomed to seeing and using in our clinical practice. And the axial map is really, really good at looking at the treatment area. How much treatment do we get? How big is that treatment zone and how much correction do we get? So what I'm focusing on here is basically that central blue circle. I want to make sure that I'm getting the vision correction that I anticipated, that blue area is nice and uniform within the pupil area, and I'm getting a centered treatment zone. And the axial map is absolutely beautiful at showing that, especially a difference map. Make sure your topographer has the capability of doing difference or subtractive maps. So having a baseline topography and then a post-Ortho-K map, and then showing what that difference is. That's what you'll be utilizing a lot. So when do we use the axial map for modifications? When there's not enough of a treatment effect. So if the treatment zone is decentered, that can cause glare and halos. So the axial map will show, is it in the proper centered position in the pupil area? Also, for myopia control, we want to make sure that not only is the treatment zone within the pupil, but we have some of that peripheral plus getting in there as well. Now, if it's an adult patient and we're doing Ortho-K for vision correction, not for myopia control, then that's not as important. We may want that treatment zone to encompass the entire area. So if you have an adult patient and they're coming in complaining of nighttime glare and halos, you can see how much of that treatment zone is within that pupil area, and you can increase it or lower it as you need. This is probably what you'll use the most, to be honest, because tangential maps are great at showing shape and the changes we're making to the shape of the cornea. And that's what Ortho-K is about. We're changing the shape of the cornea with these hydraulic forces. So for centration issues, I'll be using tangential maps and specifically tangential difference maps, seeing if the design is decentering inferiorly or superiorly or laterally. The tangential map is fantastic at that. It also can show if we're getting enough of that mid-peripheral steepening within the pupil area. So on this particular map, you want some of that red ring within that pupil area, which is that dark circle. So you want the treatment area, which is the blue area, nice and well centered, but enough of the red ring still within the pupil where we're having some of that peripheral myopic defocus. And when we use the tangential map for modifications is for the zones that are important for centration. So the reverse curve, the alignment curves, anything that's used to modify how that lens is fitting, that's when we use a tangential map. So not the base curve, right? The base curve is not going to be modified too much from tangential map analysis because that's not the fitting curve, that's the treatment curve. But when the lenses are not fitting properly, we're going to be modifying reverse and alignment zones, and we'll be using tangential maps primarily to see what's going on. The refractive map is very similar to the axial map. It shows the treatment zone, and it shows the amount of myopia you've corrected, or hyperopia. So this is a good objective finding to have. A lot of these patients are going to be young kids, and manifest refractions may not be very accurate. Certainly can get out your retinoscope and get accurate results that way, but having a topography that shows the amount of refractive correction you've done on the cornea can be very valuable. So using the refractive difference map, I can go in before I even see the patient, see, all right, I've corrected 4 diopters of myopia, 5 diopters of myopia on this corneal surface. And if my manifest refraction doesn't equate because the kid's just tired that day or just all over the place, at least I have an objective finding to back me up. And again, similar to the axial map, it shows that treatment area very well if it's well centered and within that pupil zone. All right, and the elevation map, this I use primarily for design purposes. So right when I'm deciding what type of Ortho-K lens to use. So the elevations map show me the difference from basically a best fit sphere over that central cornea. So it shows me the differences in the principal meridian. It shows, is the vertical meridian very different in that periphery compared to the horizontal meridian? That's important because if I have a spherical design all the way around, but the elevation is completely different, my lens isn't going to center properly. It's not going to land on the cornea at equal places on the eye. So knowing that elevation difference is important to design a spherical Ortho-K retainer or a toric Ortho-K retainer. And this is really my guideline. If I have less than about 30 microns, 25 to 30 microns of elevation difference between the principal meridians, a spherical design will typically work. If I have more than 25 to 30 microns, I'm going with toric. And I found, especially over the last several years, more and more of my designs are being toric. And that elevation difference is typically measured at the 8mm chord because that's where most alignment curves are landing. And depending on your topographer, that instrument can measure this directly. It'll have a difference in elevation at the principal meridian at whatever chord length you set, and you can have it pre-analyze the amount of elevation difference. So in my topographer, which is a MedMod, on the side of the analysis, I see what the flat K is and steep K, and then there's a little area that says this is the difference in elevation at 8mm. So nothing I have to do manually, the topographer will calculate it for me. Topography, I mentioned, is really important. I think you definitely need it for Ortho-K. So you got to get good images. And we're going to go over some good and bad images. And at baseline, take images over and over. Even if you're having trouble with the kid, you get one shot at getting a baseline topographer. So make sure it's a good one. Take 10, 12 images if you need to. That's commonplace for our practice. I really won't let an Ortho-K patient go unless I get a topography that looks like this. So if you look at the left placido rings, you'll see that they're all uniformly spaced out. There's no what's called ring jam where the placido rings are smeared or jamming into the adjacent ones. No tear film issues. All the lids and lashes are out of the way, and the entire cornea is mapped. This is what you want to see for your topography. This is another great capture where you're not seeing the artifacts from the lids and lashes. This, you can tell, is not great. You can't design an Ortho-K retainer from this topography. There's just way too much information missing. Same thing with this one. Not only is information missing, you can see the lid architecture, but that's going to give you artifacts. This is not a true representation of what this cornea is like. If I try to design an Ortho-K retainer based on this map, it'll be all over the place because there's just too much artifact in the way. And I get it. In clinical practice, I get this question a lot. Come on, doc, you really expect me to get this every single time? That's just not, that's textbook. Textbook doesn't happen in the real world. For Ortho-K, you got to get it. You have to, and no matter how many maps it takes, because if you start designing with the topography like this, you're off to a rough start. And I know that it's tough to get because these are my images. These are patients that we had. So this is a scan that we got in clinic. And I said, nope, this is not good enough. We gotta keep going and get a better image because we can't design off of this. And even though this seems like a decent topography, you can kind of tell the amount of astigmatism and it looks apical there. This is still a poor image capture. You can't design off of this because you're missing so much of that mid-peripheral cornea. That's where the alignment curve is landing. That's where you can decide if you need a toric or spherical landing zones. So much critical information is missing with this topography. This would actually be an unacceptable topography map to start an ortho-K design. Now let's get into when things go wrong. And they will. As you get better and better, you'll have less and less visits, I'm sure, but you'll encounter problems along the way. And the issue is not to avoid the problems, but know what to do when they come up. So smiley face, this is actually a term that ortho-K docs use, the smiley face topography. And really all it means is a superior decentration. So you can see on the map on the right, you see this kind of yellow orange area underneath the blue circle, and it looks like a smiley face. And that depiction happens because the lens is riding high and it's causing a superior decentered treatment zone. So you're going to see some of that reverse curve underneath it, but the reverse curve superiorly is out of the image. So you'll see what looks like a smiley face. So all a smiley face topography means superior decentration. And what causes superior decentration? There's just too little sagittal depth. Or another way to put it, you could say it's too flat. The lens is designed too flat. I prefer to use sagittal depth. I think that's a more accurate representation instead of saying flat or loose. That can be confusing when you're used to RGP design. So too little sagittal depth will cause superior decentration. So to fix it, you obviously increase it. So to increase the sagittal depth of design, you steepen your reverse curves or steepen the alignment curves. And that'll increase that sagittal depth and improve that centration. Frowny face, as you might guess, is the exact opposite. The maps will be decentered inferiorly. And instead of seeing that smiley face underneath the treatment zone, you'll see the superior reverse curve, which is mimicking a frowny face. And the cause is the exact opposite. You have too much sagittal depth in this case. And the way you fix it is by decreasing the sagittal depth. Decreasing the sagittal depth is accomplished by flattening the reverse curve or flattening the alignment curves. You can also adjust overall diameter, but typically you're modifying the curves first. Lateral decentration, you can see, you don't see that fully formed red ring. This design is decentering temporally on this side. Lateral decentration is by far the hardest to deal with. And the reason is anything can cause it. You might have too much sagittal depth. You might have too little sagittal depth. The diameter might be inaccurate. So it's really tough to decide how to fix this particular issue. This is where you need to use your topography and your fluorescein imaging together in tandem. And when you see lateral decentration and you see, say, too much sagittal depth, you see too much apical clearance, then on the fluorescein image, then you know, reduce that sagittal depth. If you see too little sagittal depth on the fluorescein image, then you know to increase that. So you got to use what it looks like at slit lamp with the topography in this case. But I will say, in most cases, or the best place to start if you have lateral decentration, go bigger on your overall diameter. You probably went too small. With Ortho-K, you're fitting much larger than most RGPs. You're fitting about 95% of the cornea. So whatever you measure your HVID at, you're only maybe 0.3 millimeters less than that. So that you're going to go pretty big on these Ortho-K designs. And if you don't have a large design to start off with, that may be causing some of that lateral decentration. A central island. So what I'm looking at here is that central blue area, but then right in the middle of it, you see this area green, this other area of steepening. This can be scary at first because it looks odd and the patient is going to come back seeing pretty terribly. And in some cases, actually worse than pre-treatment. So you can have a -3 patient that you put in Ortho-K. A few weeks later, they come up with a central island like this. They might be -350. They might be worse off than you started, and that can definitely throw you off. But your topography will show you what's going on and guide you what the modification can be. So what causes the central island is when there's too much sagittal depth. This is lifting up too much, and that's causing that central epithelium to kind of sink in and cause that central island right in the center and cause those visual issues. There's too much sagittal depth when you have a central island. So to fix it, again, we reduce the sagittal depth. This is very similar to the frowny face design topography. So we flattened the reverse curve. And I'll show this here. This was a patient that came in and had a central island, and we picked it up right away on the topography. So rest assured, we let mom and dad know, hey, this is to be expected. We know what's going on. We just make a slight modification, flatten that reverse curve by a diopter. 2 weeks later, bam, back to 20/20, and a nice center treatment. A false central island is different. And it's important to distinguish these two because they're caused by different things and they're treated completely opposite. So while they look similar on topography, you see that central steepening is not as big. And the reason for this is not true sagittal, too much sagittal depth. This is caused by mechanical compression. So this is when the base curve is too flat and it's actually rubbing up against the cornea and it's causing central SBK. And the topography is misinterpreting that epithelial disruption as steepening. So you'll see on a difference map, this little area of central steepening, that's not a true central island, that's SBK. And the way to tell the difference is look at the cornea. Stain the cornea with nothing on, you'll see central SBK. You shouldn't see central SBK in a true central island because it's not rubbing against the cornea. False central island, that central base curve is rubbing against the central corneal tissue, causing keratitis, and the cornea is just misinterpreting that. So this particular problem is actually caused by too little sagittal depth because it's rubbing on the cornea. So you need to increase the sagittal depth to fix it. It's the complete opposite from a true central island. So it's important to differentiate these two because they're caused by different things, and more importantly, you fix them completely different. What this arrow is showing is in a false central island, you'll see this little bump of steepening, but it's not very much. In a true central island, that bump will be much higher. So if you see this map, it goes from -5 to +5. And that 0 basically means they're planar refraction. Well, in a true central island, they'll be above that 0. You won't have that planar refraction anymore. You'll probably be the opposite of what you intended. So that bump will come up across that 0 threshold. And that's another way you can delineate if it's a true central island versus false central island. And again, the easiest way is just stain the cornea and you'll see central SBK in a false central island. So again, how do we fix it? We need to increase that sagittal depth, very similar to a smiley face. For toric designs, I mentioned the way that I determine if I'm going toric is by those elevation maps. And we do need to differentiate apical and limbus to limbus astigmatism. They're very different. So in this cornea, the astigmatism is pretty much central. We can all agree this astigmatism is different. It's extending all the way to the limbus. So that's treated differently. And for most apical astigmatism, which was this here, which right in the center, you can correct almost all of that with a central design. You can see that the mid-peripheral cornea is fairly symmetrical. You're not seeing big elevation differences. So you could probably fit that with a spherical design and have great success. With limbus to limbus, there's more likely big elevation differences, so you'll need a toric design. Remember, when you're going spherical or toric in Ortho-K, it's like scleral lenses. It's not a refractive issue. This is the cornea toric or spherical. So you're fitting what the eye looks like. So you could have -1, -150 refractive cylinder. That's not what's going to dictate whether you're picking a toric design or not. It's going to depend on that elevation difference. Is the cornea itself toric? And this is a MedMont where you can directly calculate those elevation differences. You can go in the analysis tab and it'll have a weighted amount. It'll show this is what the flat meridian is, 1065.8. This is what the steep meridian is, 1126.7 at an 8mm cord. You can change that to match whatever design you're using. And then it'll calculate it. And it'll say, hey, the difference between the flat and the steep is 60.9 microns. That's greater than 30. So guess what? We're going to go toric. All right. So I know we went through a lot. I'm sure there'll be questions to come. But before we get into that, I just want to say there are a lot of great resources to learn more and more about myopia control and Ortho-K. Here are two great ones. If you are not a member of the AAOMC, I highly recommend it for a couple of reasons. A lot of resources to learn more about myopia control and Ortho-K, troubleshooting, how to design, topography interpretation. There's annual conference. There's an annual conference, Vision by Design, where there's boot camp for newcomers, and there's even for experienced fitters, so much information to learn and grow and really enhance your skills. And not only that, it's a group that's filled with doctors that are passionate about ortho-K and myopia control. And they really want to have the rest of our profession embrace it, and very willing to go out of their way to teach you how to do ortho-K and how to implement your practice, and even practice management pearls. So as a member myself, I highly recommend looking into the AAOMC and joining. You won't regret it. It'll really change your outlook on how to practice, especially if you're wanting to embrace myopia control and ortho-K. GP Lens Institute is another great resource, not only for ortho-K and myopia control, but for all specialty contact lenses. I highly recommend them both. And with that, I want to thank you for your time, and this is the time for questions.
Welcome, Dr. Pillai. We have so many questions from the session. Everyone was just so excited about the material that you presented. I know me, I actually questioned why I'm not fitting ortho-K lenses. I was thinking about my history. I used to be a mechanical engineer and was like, why am I not doing this? It's so much about, pushing, pulling, and really restructuring to help refractive error. So welcome.
Thank you so much for having me, obviously. Yep.
Yeah, so let's start off with an easy question. What about insurance coverage for Ortho-K? How are people paying for this? How is it working?
So I will just speak for my practice. It's completely private pay. It's not covered by insurances. I have heard in certain states that there are certain plans that have some type of Ortho-K coverage, and that was in the past. They may have gotten away from it. But from my understanding, at least in Texas, it's almost explicitly said that no coverage for Ortho-K. So everything that we do is completely private pay. And to be honest, I think most Ortho-K doctors want to kind of keep it that way.
Yeah, no, that definitely makes sense for the work that goes in and kind of the thought process. We deserve our money, right? Have you had success with doing Ortho-K in adults as well as more in the myopia control area?
That's a great question. We probably started implementing and really targeting adults in the last year and a half. So just what I mean by targeting is just offering it. Every patient that comes in, whether they're presbyopic, if they just have myopia, hyper, whatever, I just tell my staff, just offer it to everybody, and the doctor will decide if they're a good candidate. And I was so shocked of how many adults were interested in Ortho-K. You would just think, oh, they want to go into refractive surgery. But there's a lot of patients that just say, I don't want to do surgery. They have extremely dry eyes, or they're outside the parameters of LASIK for whatever reason, whether it's refractive error or pachymetry, et cetera. And they really are excited about the possibility of having Ortho-K. So I think offering it in your practice to everybody, you'll be surprised of how many adults are actually interested into it. And we've had great success with it.
That's really great. When you've had Ortho-K patients, and like, let's think about the dynamics of the cornea. If you were to take someone out of an Ortho-K lens, does the cornea go back like exactly to how it was to begin with, like returning original shape? And if so, does that mean that Ortho-K can be something that we can really use long-term?
Yeah, so in my experience of when I have a child that's been in Ortho-K long-term and they become an adult and hopefully they haven't progressed as much as we wanted to. I've seen as much as 70% reduction in myopia progression compared to if we just did spectacle correction with some of these customized Ortho-K designs. I think that the cornea does resume baseline topography, and they can go forward with refractive error correction, whether it's LASIK, PRK, whatever it is. So I found really good results of patients returning to that baseline topographical images. Now, I have seen some studies where some residual astigmatism or unbounded astigmatism that happened after Ortho-K. So there's a lot of research still be done is, well, was that due to an improperly fit Ortho-K design compared to how much things have changed with the more customized designs where we're not impacting that cornea as much as, say, 10 years ago. So in my experience, I found that most patients do return to that baseline topography or pretty close to it. And I always like to say to the parents is, they're at a high level of myopia. If I can keep you at this level, then maybe refractive procedures can be an option later on, where if we're continuing down this track, maybe that won't be an option.
Yeah, that's great education for parents. Let's talk about ill-fitting lenses. Like, how do we fix some of these issues? So if you had a patient who had some nasal decentration, how would you adjust the alignment curve in order to correct this?
That's such a great question. And I think I addressed it a little bit in the lecture. Definitely lateral decentration, whether it's temporally or nasally, is by far the most difficult one. And I lean a lot on my topography images, especially the difference maps. But I will say for lateral decentration, I got to use the combination of my fluorescein capture at the slit lamp in addition to my topographical images. So a lot of times, I probably would just go a diameter change. That's probably 90% of the case is I went too small initially and I got to make an overall diameter change. But if I selected that correctly, I can go steeper or flatter on the alignment curve. And what's going to dictate that is what does the fluorescein image look like at the slit lamp? So do I see that 360 alignment on slit lamp? And if I see some areas where the tear film is pooling up, where I see some of that fluorescein is creeping in, I know I need to tighten those areas, okay? Also, obviously, if there's any type of keratitis, that's not indicated. I think I harped on that pretty well during the lectures that we don't want any type of keratitis in the cornea. That's not the goal with Ortho-K. So got to look at the topography, but in addition, the fluorescein image when you have lateral decentration, and that'll really guide you whether you want to flatten or steepen the alignment curve. And what's going to guide that is, do you see any type of fluorescein seepage in certain meridians? And those are the areas you want to start to tighten up.
Okay. Oh, excellent. Let's talk about treatment zone. So what is the standard or appropriate treatment zone right now? Is that something that we always want to go for the same number, or is it something that's variable?
That's a great question. And if you ask 10 different doctors that do a lot of Ortho-K, they probably have 10 different answers. So I think smaller treatment zone is the way we're probably headed. And that's my preference. I like to go, if it's high myopia, about a 5.5 millimeter treatment zone is what I'm aiming for. But there's some controversy here. And the reason for that is we've treated high myopia for several years. And a lot of these designs have had 6 millimeters, 6.2 millimeters, and we've had great myopia control effect. Well, why is that? Well, it's not just because of the size of the treatment zone. And this gets into optics, and I don't want to go too in the weeds here, but the reason I want to mention it is whatever size that treatment zone is, it's not the end all be all of the peripheral myopic defocus. So whatever size of that treatment zone over the pupil, you got to remember there's an entrance pupil and an exit pupil. So the optics come into play, and that measurement is definitely beyond the objective of this lecture, but that's why there's that discrepancy. That's why you see a great myopia control effect of larger treatment zones, is because a 6.0 or even a 6.2 millimeter optic zone might actually have a peripheral myopic shell on the retina that's smaller than what you anticipated because of how those light rays get onto the retina. So that's probably why we're seeing the discrepancy. There's still a lot of research to come into, but there are some good studies that show 6.0 compared to 5.5 millimeter treatment zones do have a greater myopia control effect. And especially if I'm going anything above a -5, -6, I want to try to get that treatment zone smaller because I know the studies back that up and I've seen good effects with it. And especially with kids, they're not going to complain of those side effects you're worried about with halos, with glare. They're not driving on the freeway. They're not complaining of nighttime driving issues. They can really adapt to it. And I know I'm not going to cause any issues, and I can only possibly give a benefit.
That's amazing. Really, really great, conversation there about big, small, taking into account refractive error as well. I love that.
One of the few areas where smaller might be better.
I'm thinking about, I don't do myopia control in my clinical practice. I'm not doing contact lens fits really at all. I can see one of the worries about Ortho-K lenses is that the cleanliness and the safety of those lenses. Can you explain, especially talking to a parent, trying to tell a parent that they're going to sleep in this contact lens? Can you explain why the risks are very low? And if you have any advice for speaking with parents about minimizing the risks or that having that conversation with parents?
Yeah, absolutely. I think the conversation is different when you're talking to parents compared to doctors. So when I try to explain it to doctors, you want to go to studies, and what the studies show, and this is years backing, about 7.7 per 10,000 cases. That's less than 0.1%. So very similar to soft contact lens wear is kind of how I present it to patients. And the reason why it works so well is we've got to remember, these are not silicone hydrogel lenses. These are not the regular soft contact lenses you're always preaching, don't sleep in these, don't sleep in these. These are gas permeable lenses that are not only high DK over T, but they actually allow a lot more tear exchange because they're an RGP. They're allowing that tear exchange to come in, a lot more oxygen transmissibility compared to a regular soft contact lens. And every incidence of really microbial keratitis in the literature is due to improper care, improper cleaning. It's not an issue of just wearing them too long. We don't see an increase of infectious keratitis as you wear Ortho-K retainers for more and more years. The issue is, are the kids cleaning them properly? Are they using the recommended solutions? Are they using tap water? That's really the issue in almost every study that's been done.
Oh, yeah, that's great information. Let's switch gears a little bit and go into where my head thinks of, because I typically am treating glaucoma. I know that there's been a ton of discussion recently and kind of controversial discussions about do scleral lenses affect the glaucoma, eye pressure, anything like that. Does that apply over to Ortho-K lenses? Have you seen differences in IOP measurements? Are there risks of glaucoma development by wearing an Ortho-K lens?
That's a great question. And I think it's something that we don't necessarily know the answer to yet. I think there's a few studies, if you just go online and look off PubMed, that talk about intraocular pressure variance with Ortho-K patients. I haven't found it in my clinic. And I think a big part of that is, remember, these are mostly pediatric patients. So for glaucoma to really have an impact, it's usually going to be later on in life. So as far as just intraocular pressure changes, I can't speak to that. Now, while I don't measure IOP at every single visit, we do obviously measure it at every annual exam. And I haven't seen a dramatic increase in intraocular pressure with my Ortho-K patients compared to my pediatric patients who are not an Ortho-K. So I haven't found that to have really any type of impact. And I think we can kind of look into that for pediatric patients with RGPs, because RGP patients, especially pediatric patients, they have aphakia or any other type of corneal degeneration, they're wearing it much longer than an Ortho-K patient. They're wearing it 12, 14, 16 hours a day, all waking hours. An Ortho-K patient puts it on, they go to sleep, and then 8 hours they take it off. So we're not having as much wear time. But as far as intraocular pressure itself, it's probably an area that we need to do a little bit more research, but I haven't found an impact, and certainly no increase in glaucoma risk in my practice.
Okay, that's great. And I guess if we're reducing the amount of myopia, maybe we are actually reducing the risk of glaucoma as well, since that's one of the risk factors. So maybe it's a good thing. Probably.
Absolutely. I think that's a goal. I know myopia is certainly a risk factor for developing glaucoma. It doesn't mean that you won't necessarily get it, but any risk factor that we can reduce, I think, is important. And that's a big thing we want to impact to patients, parents specifically, is, look, your child is myopic. We know that's a risk factor for these diseases later on. All right. I'm not saying that your child is going to have a retinal detachment. I'm not saying they're going to have a retinal tear, or retinal hole, or develop glaucoma. What I do know is when they're highly myopic, there is a higher risk for these things to happen. And if I can lower that risk, then the chance of them developing that is going to be much lower. And unlike in the 80s and 90s, now we can do something about it. And there's a lot of evidence that shows not only going to have that great vision correction during the day with the sociological and just getting confidence for the child, but also we can limit the risk of any type of eye disease as they enter adulthood.
That's really great. If you have one tip for practitioners who are thinking about adding Ortho-K into their practice, what would it be?
This is an easy one for me. Joining AAOMC, and I can't harp on that enough. It is an organization that's completely dedicated to myopia control and Ortho-K, and they are filled with doctors like myself that are truly passionate about myopia control and Ortho-K. And not only they're passionate about myopia control, but they're passionate about spreading the word. So if you're wanting to get into it, most of the doctors that are there want to help you incorporate it into your practice, into your clinical toolbox. So I highly recommend not only joining AAOMC, but also joining any of their Vision by Design virtual boot camps. I know that's all virtual this year. We're planning to hopefully have some live events coming up in the following years, but AOMC is a great resource. And GPLI is another one that I mentioned in my lecture. That's great for not only myopia control, but just specialty contacts in general.
Oh, that's amazing. Thank you so much for joining us for the Q&A. Your lecture was fantastic. I learned so much. Just to jump over to some notes about the event, I want to make sure everybody gets over to the Innovation Zone. If you have not done so yet, there's some amazing information from Oxervate, Zeiss, Tarsus Pharmaceuticals about new products that are greatly going to impact our profession. And make sure to jump over into the implementation track right now. Oxervate is actually going to be giving a lecture on their product. And so I think that's really a great place to go hang out and learn a little bit more. And we'll see you back here for one more lecture in about an hour.